Okay, let's unpack this. Today, we are undertaking a deep exploration of Huntington's disease HD. This is a condition that, while rare, presents one of the most compelling and, frankly, devastating riddles in modern genetics in neurology. We're not just going to touch the surface. We're diving right into the core mechanisms.
That's right. Huntington's it really challenges our understanding of what just one disease can do. I mean, affecting movement, mind, and mood all at once. So our mission for you today is pretty clear. We'll break down the precise genetic flaw that causes HD. We'll detail that harrowing triple threat of its symptoms, and critically look at the cutting-edge research, the new avenues that are bringing some genuine hope for, well, maybe even curative therapies down the line.
Okay, so let's start right at the source. At its core, HD is a genetic disorder, right? Specifically one caused by a faulty gene.
Exactly.
And the tragic result is this progressive breakdown, this steady decay of nerve cells deep within the brain.
That's it. And to get specific, we're talking about a defect on the HTT gene. That's H-PT. It sits on chromosome 4. Now, what happens isn't just a simple mistake. It's more like an expansion, almost like a stutter in the DNA code itself. See, every gene has these specific sequence repeats, and in the HTT gene, we're laser-focused on the CAG repeat. CAG.
CAG, okay, that sounds pretty technical. Can you maybe simplify what that expansion actually means for the patient?
Absolutely. Yeah, think of it like a photocopier that's just gone a bit haywire. Normally, everyone has somewhere between, say, 10 to 35 repeats of this CAG sequence. Totally normal. But if you have 40 or more of those repeats, that's the threshold. That's what leads to developing HD. And the thing is, the longer that sequence gets, the more severe the disease tends to be. And crucially, the earlier the symptoms usually start. This huge expansion causes the protein the gene makes, it's called the Huntington protein, to kind of misfold. And this toxic misfolded protein then starts, well, gumming up the works, killing nerve cells in the brain, especially in an area called the basal ganglia.
That immediately gives context to the inheritance part, which honestly sounds like one of the most frightening aspects of HD. Because if you have this faulty gene, it's dominant, correct?
Precisely. It's what we call an autosomal dominant disorder. That just means you only need one copy of the faulty gene. You could get it from your mom or your dad to develop the disease. And this is that profound mathematical certainty you hinted at. If one parent has the faulty gene, there's a clear, unavoidable 50% chance their child will inherit it. And eventually, they'll develop the disease too.
50%, wow.
Yeah. This is why family history isn't just like a risk factor. It's almost like a life sentence written right there in your genetic code.
And as we noted, even though that gene is there from conception, the physical symptoms usually hold off for a while. They typically kick in between ages 30 and 50. But that relationship you just described, the longer the CAG repeat, that determines the variation, right? So like if someone has a really high repeat count, say 60 or more.
Right. They might get what's called juvenile HD. It can appear even in childhood or adolescence, much earlier onset. Exactly. The genetics are, highly correlated with the timing. But regardless of when they start, when the symptoms do manifest, they are severe. Yeah. Because they attack the patient from 3 distinct and, frankly, brutal angles, which is why we call it the triple threat. We usually start by talking about the physical deterioration.
Right. Let's focus on that hallmark physical sign first, the one people might associate most with HD.
That would be the involuntary, almost dance-like movements, the jerking or twitching. Medically, it's known as chorea. The word chorea actually comes from the Greek word for dance. But this isn't clumsy movement. It's totally uncontrolled, fluid, sometimes flailing motion. At first, it might just look like restlessness, maybe fidgeting. But as the disease progresses, it becomes debilitating. It makes simple things like walking, eating, even speaking incredibly difficult.
And crucially, it's not just the visible motor issues. That loss of nerve cells you mentioned, the basal ganglia. That also means serious cognitive challenges start showing up too, right alongside the physical stuff.
Absolutely. Think about the brain regions being hit. The basal ganglia and its connections to the frontal cortex are vital for what we call executive function. So the disease deeply impacts things like memory, concentration, planning, making decisions step by step. Tasks that require abstract thought or organization or, quick problem solving, they become increasingly impossible. A person might look okay on the surface, but they could be struggling immensely just to complete a multi-step task at work or manage their household finances.
Okay, so you've got the increasing physical limitations, which must be isolating, and then the cognitive decline, which sounds incredibly frustrating and confusing. How does that then amplify the emotional and mood components that completes this triple threat, right?
Yeah. It creates this awful feedback loop.
Hmm.
Honestly, the emotional and mental health impact is, for many families, the most difficult aspect to manage. Patients frequently suffer from severe depression. Sometimes this starts decades before the movement issues even appear. And that's often coupled with extreme irritability, anxiety, and sometimes profound personality shifts. I mean, imagine losing control over your body and your mind while at the same time you're watching your own personality. The very essence of who you are start to fracture. It's devastating.
That relentless combination is truly terrifying. Our sources highlighted a really powerful comparison, basically trying to capture the scope of this condition.
Yes, exactly. To try and convey the severity, HD is often described as being like a blend of Alzheimer's disease, Parkinson's disease, and ALS, all rolled into one. So you get the cognitive decay similar to Alzheimer's, you get severe movement issues, rigidity, sometimes tremor, reminiscent of Parkinson's, and then you combine that with a progressive physical decline that eventually impacts vital functions like swallowing and breathing. Similar to ALS, it's just a full spectrum neurological assault.
Wow. Okay. So, faced with that kind of devastating complexity, often the first major step for a family is getting a definitive diagnosis. How reliable is that genetic testing you mentioned earlier?
It is definitive, absolutely definitive. Remember those CAG repeats we talked about? The diagnostic process is basically just counting those repeats in the HTT gene. If you have 40 or more, the diagnosis of HD is confirmed. It's a clear genetic biomarker. There's no ambiguity. This capability is incredibly powerful, medically speaking, but it immediately pushes us into one of the most agonizing ethical dilemmas in modern medicine.
Okay, here's where it gets really interesting and deeply complex for you, the listener, to consider. Because the test can confirm a diagnosis long before any physical or cognitive symptoms show up, sometimes decades before. So the question becomes, if there isn't currently a cure, what's the value or maybe the cost of knowing your future with such certainty?
It's an overwhelming decision. It really is. People thinking about testing aren't just deciding about their medical history. They're essentially deciding on their life's timeline, how they view their future. Knowing you carry the gene has immediate life-altering consequences. Think about employment, life insurance eligibility, and really deeply personal things like family planning, like deciding whether to have children and potentially pass on that 50% risk.
Right. That knowledge gives you certainty, maybe, but it feels like it could remove hope, at least in the short term. It seems like the psychological burden of getting a positive pre-symptomatic test result could be almost as immediate and impactful as the physical disease itself later on.
That is precisely why genetic counseling isn't just like recommended, it's absolutely essential. Counseling goes way beyond just explaining the science of the test. It provides structured support to help people navigate the immediate fallout of a positive result, the psychological adjustment, how to communicate within the family, and tackling those big life decisions like career paths or insurance, maybe before the results are even known. It's about preparing the individual and their family for a known but difficult future.
Okay, so turning now to intervention. After dealing with that huge diagnostic and ethical weight, the current reality of treatment is, well, it's stark. We have to state it clearly. At this moment, there is no cure for Huntington's disease.
That's the hard truth today, yeah. So the entire current strategy really focuses on managing the symptoms, maximizing function, trying to improve quality of life for as long as possible. For the chorea, those involuntary movements, there are specific medications. Tetrabenazine or deutetrabenazine can sometimes help reduce the severity by affecting certain chemicals in the brain, neurotransmitters.
And what about the depression, the anxiety, the mood changes that sound so central to the experience?
Yeah. For those, standard psychiatric treatments are used, mainly antidepressants, sometimes antipsychotics, to help manage the severe mood and personality issues. And physical therapy, occupational therapy, speech therapy, they're all vital too. They help maintain motor skills, daily living activities, and communication for as long as possible as the disease progresses.
But the focus isn't just on managing the symptoms forever, right? The real energy, the real hope is in actually stopping or reversing the disease. This brings us to the future. The research landscape, which sounds incredibly active. What are the major breakthroughs we're seeing that might promise a radical shift from just management to maybe a cure?
The paradigm shift has been profound, actually. We're no longer just aiming to treat the symptoms of the nerve cells dying. We're targeting the cause, the root problem, that faulty genetic instruction manual itself.
That sounds almost like science fiction. Can you give us a couple of specific examples? How are they actually trying to silence or correct that faulty gene?
Okay, so one of the most promising avenues right now, currently in clinical trials, is something called RNA interference, usually shortened to RNAi. Think of your DNA as the master blueprint in the cell's nucleus. RNA is like the temporary photocopy, the message sent out to the cell's factory floor to build proteins. In HD, that message tells the factory to build the toxic Huntington protein. RNAi is like introducing a specific kind of molecular shredder. It uses tiny molecules designed to find and bind to that faulty messenger RNA and basically destroy it before the toxic protein can even be made.
So stopping the problem at the source.
Exactly. By silencing the faulty instruction manual, the hope is to stop the nerve cell damage before it really takes hold, or at least slow it dramatically.
It's a conceptually brilliant approach. Sounds incredibly targeted.
It is highly targeted. Another major area uses something called antisense oligonucleotides, or ASOs. These are short synthetic strands of DNA or RNA that work in a similar way. They basically interfere with the process of making that faulty protein from the RNA message. And then, of course, there's ongoing work in gene therapy. This is more about potentially delivering corrected genes into brain cells, maybe to replace the faulty one's function or perhaps protect the cells from the toxic protein.
The pace of this research, I mean, moving from just understanding the gene defect to actively trying to interfere with how the gene is expressed, it's astounding. It feels like HD research connects to the whole field of neurological gene therapy.
Absolutely. You know, HD is kind of unique because we know the single faulty gene, and we have a pretty clear idea of its mechanism, that toxic protein buildup. So successes in developing these gene silencing or gene editing techniques for HD, they could become a critical blueprint. They could potentially help us tackle other complex neurological disorders down the road, maybe even some forms of Alzheimer's or Parkinson's, where the genetics are more complex. In a way, the HD community's struggle is driving innovation that might benefit many others.
So wrapping this up, what does this all mean for you, the learner, as you integrate this knowledge?
Well, I think the final takeaway is that while Huntington's disease might be statistically rare, its impact on patients and their families is just enormous. And greater awareness is absolutely key. Understanding the difference between symptom management, which is where we are today, and the real potential of things like gene silencing tomorrow. That's crucial for appreciating just how quickly modern medicine is evolving. It's a condition that really forces a conversation about genetics, about destiny, and about the power and limits of technology.
And if someone you know is navigating this incredibly complex disease, remember that knowledge and research are only part of the solution. Practical support is vital. Encourage them to reach out to HD-specific support groups, medical professionals who specialize in comprehensive, multidisciplinary HD care. Having that coordinated team approach can make a huge difference in managing the day-to-day challenges. And here's a final provocative thought for you to consider as you wrap up this deep dive. Given the success we're starting to see in early trials using these targeted molecular tools, like RNA interference, to actually silence the faulty gene tools that could potentially halt the disease, the question for the next decade might no longer be if we can correct or silence the gene. Instead, the challenge is rapidly becoming: how quickly can these incredibly complex, likely very expensive gene therapies be made truly accessible, universally available to everyone affected by this devastating disease, no matter where they live or what their resources are? Something to think about.